Welcome to tonight's Facebook Live. My name is Nancy Abdu. I am the founder of the Australian Dermal and Laser Institute, otherwise known as TADLI. Thank you for joining me tonight. Tonight is going to be a really interesting one because there was a video that went viral. Actually, it was a few months ago, and I made a comment, and we've had a lot of people commenting and actually sharing that video. But before I get into it, it actually feels really good to be back. I actually haven't done a Facebook Live in probably in about 1 or 2 years, and that changes tonight. So from now on, I'll be here every Tuesday night covering real clinical topics in aesthetics. And some weeks it'll be just myself. So it'll be just you and me. And 1 or 2 times a month, I'll be joined by respected industry experts covering various topics from the TGA to insurance to science, marketing, regulations, and so much more. Because this industry needs more education and less noise. So like I said, tonight's topic is an important one. And like I said, after that video went viral of a client who clearly was overtreated with radio frequency microneedling, and after I responded to it, like I said just before, we had so many people messaging and inquiring. So tonight I'm going to be breaking it down properly. I'm going to be talking radio frequency microneedling settings, what likely went wrong, inflammation and over-inflammatory response. I want to discuss with you aftercare, fat loss, not that that had happened to her, but I do want to talk about that because that seems to be a bit of a hot topic. Scope of practice. So that's something that is oftentimes overlooked, and what to do if this ever happens to you in your clinic. So this isn't about attacking anyone, it's just about protecting clients and protecting you as clinicians and therapists and beauty therapists. So let's have a quick overview of what radiofrequency actually is and what it does. So, and I think this is, foundational education. So let's just go back to basics. Radiofrequency microneedling works in two ways. One, mechanically, so you've got the injury from the actual needle itself penetrating, creating this mechanical trauma, and it is a controlled mechanical trauma. And the second component is a thermal injury from the radiofrequency energy delivered into the dermis. And so with the radiofrequency, what happens is this a short burst of that energy creating that thermal trauma. So the goal here is controlled wound healing. Controlled, not trauma, not aggression. It is controlled thermal coagulation zones that stimulate collagen remodeling. And of course, depth matters. So we've got the mechanical trauma, we've got the thermal trauma, but also there's a number of different parameters that actually will make a difference in our outcomes, in downtime, and in how that client or how the skin actually responds. So the first thing is the depth. We know from 0.5 to 1 millimeter, we're actually reaching that papillary dermis. And going a little bit deeper from 0.5 to 2 mil, it is that mid-deep dermis, and it depends on where on the body that we're treating. Of course, the face is going to be different from the body, different areas, and different skin thicknesses. It will vary. But so from 1.5 to 2, we're going to that deeper mid dermis. From 2.5 to 3.5, again depending on the body. You've got deep dermis, and at 4 mil plus, you're actually entering that subcutaneous tissue. On the face, it's going to be maybe that little bit more superficial, depending on my client's age and the skin integrity and what their skin is actually or has actually undergone over the years, and what they've done at home or what are the treatments. But let's just quickly see where most people get this wrong. If we're going to talk about fat sits in that subcutaneous layer. So if you're treating too deep, or if you're using overly high energies, and if your posturations are far too long and you're performing multiple passes, more than I'd say 4 passes, you're not boosting collagen. You're potentially damaging fat. So let's just quickly go back over that for a second, because there's a few things that I mentioned there. So we've got our energy. So if you're using quite a high energy, you're going to get quite a bit of ablation around the actual needle itself. All right, so we're getting coagulation, we're getting ablation, and if you're actually using a long pulse duration, what then also happens is you're actually then creating that coagulation around the end of the needle, depending if it's insulated or uninsulated. I'll come across and we'll talk about that in a second. But you're getting this, coagulation point that doesn't just look nice and, compact, but it's actually wide. And the best way I explain it is if you've got a belly flop versus a pin drop when someone's doing a dive in a swimming pool. A belly flop, you're going to get this width occurring, right? So that's your long pulse duration. You're getting a lot of coagulation occurring that's quite wide. Whereas a pin drop, and your pulse duration is your pulse duration is short, so that coagulation that's actually happening is nice and neat and compact. And it depends what you're trying to do. If we're trying to, create a little bit of, dermal remodeling and maybe, help with a little bit of that dermal laxity, then we're going to want to go a little bit wider, but you want to drop your energy. However, if you're wanting to have a different outcome, where we're treating say fine lines and wrinkles, and we're not really wanting to get that breadth or that width of the ablation, then we're going to do the opposite. You're going to use a higher power and a shorter pulse duration. You're not ever going to do both, and I think this is where people get confused with power and your pulse duration. So imagine you've got this needle going deep. And if you're doing, let's just call it 3 millimeters deep, plus you've got radio frequency, your actual energy doesn't just stop at 3 millimeters, it's actually spreading out and further down deep into the tissue. And if we actually go a little bit deeper, are we going into that subcutaneous layer, and are we actually creating lipolysis? Are we destroying those fat cells? And this is where we start seeing that loss of volume. So it's not just like needling where you've only got the depth and that's it, and how many passes of your normal needling, microneedling. There's so many different elements and facets here that are being overlooked. And my gut feeling, or my educated guess with this particular lady is, who was overtreated, I am imagining that there was a number of things happening. One was potentially the depth was too deep, I don't know. Or what I really think happened is the energy was really high and the pulse duration was super long, and it created so much trauma that downtime was aggressive and intense. And then not only that, there was home care. I'll come to that in a second. But before I do so, I want to move on to insulated versus uninsulated needles. So let's talk about these probes and needles. With uninsulated needles, the energy is delivered along the entire needle shaft. And so this is going to affect your epidermis, your dermis, and your deeper tissue, because the whole needle is not insulated. You're getting energy along the entire length of the needle. And sometimes that's okay on the right skin type, but it's pretty intense because we're getting ablation and coagulation along the whole length of that needle. So there is a higher risk of surface damage, and also there's a higher chance of, post-inflammatory hyperpigmentation if the settings and if the needles aren't used correctly. On the other hand, you've got insulated needles. And so what happens with insulated needles is you've got this insulation that happens down the length of the needle, and you've got all of that heat coming out at the tip only. And so you're going to have more controlled thermal zones. It's going to be safer for deeper work when it's used correctly. But that does not always mean an equal safety, because again, it's your depth plus your power plus your duration plus the number of passes, and that equals that cumulative thermal load. And then of course you've got the insulated versus your uninsulated. So that could be another thing that went wrong, is we're using all of these high energies and longer pulse durations, plus uninsulated needles potentially could have been used. So there's a whole, like I said, it's not as easy as what you think it is. You can't just buy a device and think, oh yeah, I'm just going to sort of give it a crack. It doesn't work like that. You really need to understand the device. You need to understand the parameters. And I think really this is probably where this viral case has actually most likely gone wrong. And so, can the settings be overdone? 100% yes. And the most common mistakes, I see are, treating maximum depth on the first session, multiple aggressive passes at the same depth, rather than going, yep, I'm going to go in at my 2.5 and my 1 and say my 0.5, depending where it is on the face and the body. But the person has done multiple passes at 2 mil and then 2 mil and then 2 mil. Well, what are you doing? We're over treating, the skin, right? Or potentially the other thing, like I said a number of times, is high power with long pulse duration. There's no stacking strategy. The clients haven't been skin prepped adequately. There's been no inflammatory assessment done on that skin type. No Fitzpatrick consideration. Even though RF is colorblind, and we always say, yep, you can treat all skin types with RF and with needling, but nonetheless, we're still creating this thermal trauma, right? And here's the biggest red flag. When a client is in severe pain and the clinician says, oh, that's normal. No, it's not normal, which is what's happened with this particular client. She was told it was normal. Mild discomfort, yeah. Severe, intolerable pain, that's feedback. And that pain can indicate excessive thermal load, nerve stimulation, inadequate topical anesthetic timing. So with RF microneedling, I always recommend people have or apply topical anesthetic. So it could be inadequate topical numbing, poor technique, or treating beyond the skin's tolerance. Pain, and that pain feedback is data. And it's definitely not something you want to be dismissing. You want to listen to your clients, no matter what treatment you're performing, whether it's laser or IPL or microneedling or RF microneedling or whatever it might be. We need to listen to the client's response, and that is data you need to be processing, and you need to be taking it on board, look, assess, and see what's happening to the skin. So I think that's one component. The second component that I want to discuss tonight is inflammation and the over-inflammation or the inflammatory response. So let's talk physiology for a sec. When we create controlled injury, we trigger three things: an inflammatory phase, the second phase of wound healing, which is our proliferative phase, And our third phase is our remodeling or maturation. But when injury exceeds the skin's capacity to regulate inflammation, you're going to get prolonged erythema, extensive edema, barrier breakdown, potentially post-inflammatory hyperpigmentation depending on their Fitzpatrick, or the other way where we're actually losing that pigmentation in the skin. So instead of hyperpigmentation, we're getting hypopigmentation. Client is experiencing delayed healing. There potentially could be that fibrotic change in the skin, lipolysis, or what we call fat atrophy, or we're losing that fat in the skin, chronic sensitivity, and that could be transient or permanent, so short-term or long-term, and exaggerated inflammatory response increases your cytokines such as your interleukin 1, interleukin 10, and TNF alpha. And so these then delay healing, and it increases that melanocyte stimulation. And oftentimes when I'm talking about trauma and pigmentation, that over-inflammation and that wound healing, this is when we start seeing that excited melanocyte activity and an overproduction of those packets of melanin. And this is why some clients end up worse. And so you need to take all of these into consideration. Inflammation is okay. It's when it's long-term, non-stop inflammation, when the skin hasn't had the time to recover and bounce back, and that's when we run into problems. In fact, I'm going to be talking about inflammation with Professor Christoph Hagemeyer in one of our podcasts. I'll talk to you about that a little bit later on. But I know I'm running out of time now, but I want to quickly go over Aftercare. And was it even covered in this client's consultation? If a client walks away without strict barrier repair guidance, anti-inflammatory support, UV avoidance instructions, they need to stay out of the sunlight, clear timelines of what they're going to expect, between day 1 and day 3, this is what they're going to look like. Between, day 4 to day 10, this is what they're going to experience. And if clients aren't explained the warning signs, then that's negligence. It's not something that, like Aftercare isn't, use something gentle. That's not Aftercare. Aftercare isn't, just, put some sunscreen and you'll be right. Aftercare should include barrier support, ceramides, cholesterol, fatty acids, things that are going to help with chill transepidermal water loss, something that's going to help with the inflammation, so anti-inflammatory actives, LED. You all know how much I love LED. So Aftercare and pre-care too should involve LED support, definitely strict SPF that's not, in my opinion, not chemical. No heat, no gym, no saunas, no jacuzzis, no swimming pools, no chlorine, no beach, nothing, I would say, until that inflammation has gone down. So I would say even 3 days. And in fact, I don't like my clients to wash their face for the first 24 hours. They're not to get their skin wet. And definitely no actives until that sandpapery feeling has sort of subsided and it feels normal. And the thing is, you need to document it. It needs to be in writing what is the aftercare. If they're not leaving with a sheet with this is the aftercare, this is what they're expecting from, day X to day Y and so forth, that's not aftercare, and it's negligence. So I know I've quickly spoken about fat loss, but really quickly, once again, can radio frequency cause fat loss? Yes, it can, but I still love the treatment when it's performed right. So the time when we see radio frequency microneedling causing fat loss is when there's, like I said, excess depth, excess energy, repeated aggressive sessions, not allowing that skin to recover and bounce back and just to do its healing, treating the wrong skin. When I say type, but I'm not talking about Fitzpatrick, I'm talking about dermal degradation. So treating thin skin, treating over bony areas, or if you're treating, say, in the temple area, or the lateral cheek, in lean clients, then you shouldn't be treating them. Or the around the orbital area, if you're treating that real thin area and you're performing multiple passes in deep, of course they're going to be losing a bit of fat around there. Once fat is gone, it's gone. And if you don't understand anatomy, you shouldn't be setting your depths at 2 or 3 or 4 millimeters. And if you don't understand anatomy, you just shouldn't be doing this treatment, full stop. So that's my opinion. So before we sort of wrap things up, what to do if this happens in your clinic? Let's say you realize you've overtreated someone. What you should be doing, one, is you do not minimize your client's concern. Bring them back in immediately, document everything, absolutely everything, from your settings to what you're seeing, to take photos. You want to document everything. Initiate aggressive barrier repair protocol, and that includes your LED therapy. And some of you may know I love my Apollo Duet because it's got your cryotherapy and your electroporation, which is calming and soothing and healing. So LED, red, green, infrared. You want to consider short-term anti-inflammatory intervention if it's within your scope. If not, you need to refer, right? And this is where your scope of practice matters. If you don't know how to manage a complication, why are you performing the procedure? That's not harsh, that's responsible. So that's your scope of practice. You're responsible for that. So just because you can purchase a device doesn't mean you're clinically equipped to manage its complications. If you can't confidently manage PAH, persistent erythema, fat atrophy concerns, barrier collapse, then you need further training. Or you just don't do, the treatment. And that includes infection risk. All right, these devices are powerful. I always say that they're a weapon in the wrong hands. And yes, you're at the mercy of your trainer. You can have an amazing device and your training is poor. You're going to also get poor results, right? You are at the mercy of the trainer, 100%. I agree with that, which is, it is what it is, right? But question everything. When you're getting trained, question everything. There's nothing wrong with asking silly questions. In my training, no question's a silly question. This is what you're here for. So we know these devices are powerful, energy is powerful, and education must match that power, 100%, all right? I think the industry needs to let go of ego. We need to, stop this more is better. We need to let, less of this turn it up higher for better results, less chasing dramatic before and afters. We're not allowed to advertise them anyway, right? And I want to see more assessment, more skin preparation, conservative first sessions and treatments, more treatment planning, right? Long-term treatment planning, documentation, and slow, strategic collagen stimulation, right? All of that is going to be one aggressive trauma session, isn't it? Anyway, so before I wrap up and finish, let me update you on what's happening at TADLI over the next few months. We have so many things going on. We're launching our microcurrent sculpting device through Skin Individual. We've also got and this is probably, I'm dropping it here a little bit too early, but our Skindividual exosome sheet masks that are going to be healing, rejuvenating, amazing for post-RF microneedling, for ablative laser, for CO2 erbium laser, for any treatment, plasma included, where there's actually that superficial trauma. These exosome sheet masks, I can't wait. They're going to be delivered in the next couple of months. So if you're interested, DM us and we'll put you on our wait list. We also have a new, I don't know if I'm allowed to say, but let's just say Photon X. That's all I'm going to say. There is a new device that's going to be launched really soon, March actually. There's some new Laramide skincare being launched, and we have just launched the Laramide body skincare. So it is so exciting. And last but not least, our brand new Science Behind Aesthetics podcast with Professor Christoph Hagemeyer. It is so exciting. He comes from a scientific clinical research backing. He has so much knowledge on nanoparticles, exosomes, on chemistry, on anatomy even. There is so much backing there. He's written, I can't remember exactly how many clinical papers now, he's going to kill me, but over 100 clinical papers, peer-reviewed papers. So the knowledge is there, and I'm going to come from a clinical perspective, and together our brains are just going to like, anyway, looking forward to that. So 2026 is about deeper science, better protocols, and stronger foundations. So if tonight resonated with you, share this episode. I would love for you to do that. If you learned something, make a comment down below. And if you want future topics covered, drop them below. Next Tuesday, 8 p.m. we continue, because education should never stop. And remember, if you don't know how to fix a complication, you're not ready to cause one. All right, 8:30, spot on. Good night, everyone, and I will see you next Tuesday. Bye. Don't know how to stop this.